Hello, I'm Dr. Jeffrey Hayes, the ASRM Education Specialist, and the following presentation is a review of our Practice Committee opinion on fertility preservation in patients undergoing gonadotoxic therapy or gonadectomy. Over 200,000 individuals less than 49 years of age are diagnosed with cancer annually in the United States. Over the past 4 decades, advancements in cancer therapies, particularly chemotherapeutics, have led to dramatic improvements in survival. Given the reproductive risks of cancer therapies in both children and those of reproductive age, and improved long-term survival, there has been growing interest in expanding the reproductive options for cancer patients. Referring healthcare providers should be available to provide patients with rapid access on reproductive risks and fertility preservation options, and clinics offering fertility preservation should have immediate ovarian stimulation and sperm cryopreservation provided without delay. Possible collaborative interdisciplinary teams may be comprised of oncologists, reproductive endocrinologists and urologists, and reproductive surgeons trained in fertility preservation techniques. Fertility preservation programs should be capable year-round to provide ART program access, cryopreservation of testicular tissue and sperm, and various age group counseling. Counseling options concerning medical considerations should include options for talking with mental health professionals, genetic counselors, and financial counselors. For post-pubertal females who have a committed male partner or who are prepared to use donor sperm, embryo cryopreservation is an established technology that offers a predictable likelihood of success based on the number and quality of embryos stored. If embryos are cryopreserved, a patient's future live birth prognosis may be further modified by the number and quality of the embryos or pre-implantation genetic testing results when performed. These success rates decline with age. Until more data in diverse populations become available, national and clinic-specific success rates using cryopreserved embryos should be used to counsel patients regarding success rates. Mature oocyte cryopreservation is another strategy for fertility preservation in postpubertal females. This process also requires ovarian stimulation and egg retrieval. Cryopreservation of oocytes rather than embryos allows for greater control of disposition of the individual's gametes in the future and also avoids issues related to embryo disposition. As with embryo cryopreservation, pregnancy rates following oocyte cryopreservation decline with advancing age of the woman. It is important to recognize that success rates may not be generalizable, and clinic-specific success rates should be used to counsel patients whenever possible. Ovarian stimulation for embryo or mature oocyte cryopreservation remains the most likely strategy to result in subsequent pregnancy. This procedure should be recommended as long as the patient's medical condition safely allows controlled ovarian stimulation, or COS, with a reasonable chance of response or oocyte retrieval, and if there is adequate time to carry out COS and oocyte retrieval. In the setting of emergent fertility preservation, initiation of the stimulation should start as soon as possible regardless of phase of menstrual cycle, so-called immediate or random start COS. Compared with conventional stimulation, immediate start stimulations have similar embryological and pregnancy outcomes. Prompt consultation and coordination of care is mandatory to facilitate initiation of treatment and avoid unnecessary delay. Some studies have suggested that stimulation and oocyte yields may be impaired in patients with cancer who have not yet received gonadotoxic therapies. For more detailed information on these studies and this topic, please click on the link at the end of this presentation to access the committee opinion and go to page 1024. Ovarian tissue banking is an acceptable fertility preservation technique and is no longer considered experimental. Cryopreservation of ovarian cortical tissue theoretically represents an efficient way of preserving thousands of ovarian follicles at one time. This technique has been proposed principally for prepubertal females and those who cannot delay cancer treatment in order to undergo ovarian stimulation and oocyte retrieval, as it does not appear to be feasible to cryopreserve ovarian tissue from women older than 40 years of age. In patients younger than 40 years, that amount of ovarian tissue cryopreserved theoretically should be proportional to the risk of age-related diminished follicular reserve. Overall data on the efficacy, safety, and reproductive outcomes after ovarian tissue cryopreservation are still limited. Given the current body of literature, ovarian tissue cryopreservation should be considered an established medical procedure with limited effectiveness that should be offered to carefully selected patients. Ovarian tissue transplantation can be technically challenging and should be offered only by centers with the necessary laboratory and surgical expertise. Several randomized trials and meta-analysis have explored the benefits of GnRH analogs during chemotherapy. However, the use of GnRH analogs for ovarian protection during chemotherapy remains controversial. Given the evidence of efficacy, GnRH agonists may be offered to breast cancer patients to reduce the risks or premature ovarian insufficiency, but should not be used in place of other fertility preservation alternatives. Further studies are required to establish the efficacy of this treatment and to determine which patients are the best candidates for its use. Nonetheless, this therapy may help to prevent heavy bleeding in patients with thrombocytopenia related to chemotherapy and stem cell transplantation and should be considered in such patients. Patients requiring local pelvic radiation treatment may benefit from transposition of the ovaries to sites away from maximal radiation exposure. Ovarian transposition may be accomplished at the time of initial oncologic surgery or at a later time. It is important to recognize that this procedure may preclude future transvaginal oocyte retrieval if IVF is required. Transabdominal retrieval may be accomplished in some patients. Patients undergoing surgery for cervical, endometrial, or ovarian cancer, or borderline tumors of the ovary may be candidates for conservative surgical approaches or, in case of endometrial disease, initial medical therapy. Patients should discuss treatment options with a gynecologic oncologist. Special clinical considerations for female patients include breast cancer, BRCA mutations, gynecologic malignancies, hematologic malignancies, and children and adolescents. Counseling all males about the reproductive risks of cancer treatment and availability of fertility preservation options prior to initiation of cancer therapy and consideration of referral to a reproductive urologist is recommended. Semen collection by masturbation is feasible and successful in the majority of adults and postpubertal male patients with cancer and should be performed prior to the administration of gonadotoxic therapies such as chemotherapy or radiation therapy. Ideally, at least 2 to 3 ejaculated samples should be obtained to provide adequate numbers of sperm sufficient to yield several vials for cryopreservation. For young men or men who are unable to ejaculate, the following therapeutic options can be considered to obtain ejaculated sperm for cryopreservation. Use of phosphodiesterase type 5 or PDE5 inhibitors, vibratory stimulation, electroejaculation, or retrograde ejaculation. Surgical sperm extraction is an alternative strategy for males who cannot ejaculate via the aforementioned techniques, or now have azoospermia or insufficient sperm in the ejaculate to freeze. GnRH analogs have been used to suppress the hypothalamic pituitary gonadal axis during chemotherapy administration in an effort to protect the germinal epithelium. However, after studies conducted, it is not appropriate to use in males for fertility preservation. Testicular tissue cryopreservation is the only method to preserve the fertility of prepubertal boys who are not yet producing sperm, or for pubertal patients who cannot or will not produce a semen sample. Animal research demonstrates the feasibility and safety of next-generation reproductive technologies using frozen and thawed testicular tissues. No human live births have been reported using those technologies, so immature testicular tissue cryopreservation should be considered experimental and offered only to patients who are prepubertal and at significant risk of infertility due to their disease or medical treatment, and as part of a clinical trial. Men suspected of having testicular cancer can be offered sperm cryopreservation prior to orchiectomy. This is an especially important consideration for men with a solitary testis or contralateral testicular atrophy. In summary, patients facing treatments likely to impair reproductive function deserve prompt counseling regarding their options for fertility preservation and rapid referral to an appropriate program. Embryo, oocyte, and ejaculated or testicular sperm cryopreservation remain the principal established modalities for fertility preservation. Ovarian tissue cryopreservation is no longer considered experimental and can be used in prepubertal patients or when there is not time for ovarian stimulation. Testicular tissue cryopreservation in prepubertal males is still considered experimental and should be conducted under research protocols when no other options are feasible. GnRH agonists can be offered to women with breast cancer and potentially other cancers for the purpose of protection from ovarian insufficiency, However, GnRH analogs should not replace oocyte of embryo cryopreservation as the established modalities for fertility preservation. GnRH agonist therapy is not effective in preserving fertility in men and is not recommended. Ovarian transposition may be offered to women undergoing pelvic radiation. For more information on this topic and a full reference list, please click on the link on the next slide to access the complete practice committee opinion on fertility preservation in patients undergoing gonadotoxic therapy or gonadectomy.